So now, without further ado, I'm really pleased to be able to introduce our first speaker today, Commander Shary Jones. Commander Jones is a U.S. Public Health Service Commission Corps officer who serves as the Acting Regional Health Administrator for the U.S. Department and Health Human Services Office of the Assistant Secretary for Health in Region 7. Prior to joining Region 7 in June 2014, as the Deputy Regional Health Administrator, Commander Jones served as a Public Health Advisor in the National Vaccine Program Office by providing oversight and guidance for the Interagency Adult Immunization Task Force. Commander Jones' experience is extensive, ranging from public health to HIV/AIDS and health policy. She is also a board-certified pharmacotherapy specialist and certified immunizing pharmacist. Please join me in providing Commander Jones a warm welcome. I hope you were able to hear our applause and welcome, Commander Jones.
Hi, good morning. Thank you for the introduction. I really appreciate it. And so I'll spend the next 25 minutes or so talking about the role of the Department of Health and Human Services in addressing diabetes prevention and control. We have a few objectives. Wanted to talk about HHS's role in addressing diabetes prevention and control and how we can provide support for state and local partner stakeholders, and also discuss potential impact on healthcare reform has on diabetes management. And as a disclaimer, the information presented today will be from the current administration's perspective, as we're unsure of how we will unfold with the new administration coming. So to give a brief overview of the presentation, we'll specifically talk about the Office of the Assistant Secretary for Health, OASH, and how they fit in within HHS, current OASH priorities, and healthcare reform and diabetes. So a little bit on the Office of the Assistant Secretary for Health. Here is, the HHS Organizational Structure. It's a org chart. And HHS accomplishes its mission through programs and initiatives that cover a wide spectrum of activities serving Americans at every stage of life. There are 11 operating divisions, including 8 agencies in the U.S. Public Health Service and 3 human services agencies that administer HHS's programs. And those can be found in the middle 8th section of this organizational chart. And so I'm sure you'll hear from Patricia next, who works for one of the major operating divisions, the CDC. In addition, staff divisions, which are the ones located on the perimeters, provide leadership, direction, and policy management guidance to the department. And the Office of Assistant Secretary for Health is a staff division and is located on the left of this organizational chart. And so here's a map representing the 10 regional offices of HHS, which are very similar to the Public Health Training Center operations that we just saw. A majority of the OpDivs, or operating divisions, and some of the staff divisions have representation in each region. And as you all know, Region 7 is centrally located in Kansas City, but is comprised of Missouri, Iowa, Nebraska, and Kansas. So there is a regional health administrator in each of the 10 regions, and they are primarily responsible for 3 major areas in their respective regions. They serve as a vibrant extension to OASH by putting prevention into practice, maximizing the collective prevention impact of all HHS operating and staff divisions, and also facilitating agency-wide coordination and collaboration, and we seize the opportunities for prevention as they arise in the field. Dr. Karen DeSalvo is the current Acting Assistant Secretary for Health for the U.S. Department of Health and Human Services, and is a physician who has focused her career toward improving access to affordable, high-quality care for all people, especially vulnerable populations, and promoting overall health. The Office of the Assistant Secretary for Health oversees 12 core public health offices, including the Office of the Surgeon General and the 10 regional offices as mentioned, and as well as 10 presidential and secretarial advisory committees. As you recall, staff divisions provide leadership, direction, and policy and management to the department, and the operating division serves to function in the scope of their mission related to the department. So the next slides will provide a high-level overview of the offices within the Assistant Secretary for Health. We have the National Vaccine Program Office, and some of these are self-explanatory, so I don't want to read all of them to you. So they're primarily involved with the federal agencies and vaccine and immunization activities. You have the Office of Adolescent Health that coordinates adolescent health, promotion, and disease. Office of Disease Prevention and Health Promotion, ODPHP, and they're primarily responsible for leading the Healthy People Initiative for HHS. And then you also have the Office of the Surgeon General. And so Dr. Murthy is the 19th United States Surgeon General. He has devoted himself to improving public health through the lens of service, clinical care, research, education, and entrepreneurship. The Surgeon General, or the SG, has two roles. They serve as America's doctor, and they're responsible for communicating the best available scientific information to the public regarding ways to improve personal and public health. Some initiatives include Step It Up and Turn the Tide. And in fact, the Surgeon General's report on addiction was released earlier this week. He also serves as an overseer of the operations of the U.S. Public Health Service Commission Corps, comprised of approximately 6,700 uniformed health officers who serve in nearly 800 locations around the world to promote, protect, and advance the health and safety of the nation. So the ones highlighted in yellow have regional representation and serve as resources for the support for various public health initiatives. So we have the Office of HIV, AIDS, and Infectious Disease Policy, OHADIP, which is responsible for coordinating and integrating policies and programs for the department related to HIV, AIDS, viral hepatitis. We have someone in-house that works directly with OHADIP. You have the Office of Human Research Protection, really looking at research conducted and supported by HHS. You have the Office of Minority Health, looking at the health status and quality for minority populations, and also Office of Population Affairs, advising on issues related to family planning. So those would be your Title X grants. And so with the ones in yellow, we have a team located regionally dedicated to assisting with coordination and collaboration of efforts. This could range from disseminating information, serving as speakers, convening partners and stakeholders. We even often offer grant writing assistance in some communities. Other offices include Office of Research Integrity, looking at integrity and research programs, especially in public health. Office of Women's Health, again, that one is in yellow, so we have a dedicated team here for women's health. A Presidential Commission for the Study of Bioethical Issues, looking at advances in biomedical science and technology, so that would be like precision medicine, and as well as the President Council on Fitness, Sports, and Nutrition. So just next, talk about some OASH priorities that we have. Our priorities are to enhance the quality of work as we prepare for our current leadership to transition into different roles. Public Health 3.0, which we'll talk about in just a second, and also strengthening the ability of local health departments to address two key things: the social determinants of health and ways to address the majority factors of morbidity and mortality. Our office is really keen on public health, population health, and the prevention of disease. We often examine the social determinants of health, such as the social norms and attitudes to discrimination. We have class standards, transportation options and how they are important to health, housing, homes, and neighborhoods, how your zip code impacts health. And we examine all the social determinants in several environments to guide policy for the Assistant Secretary. Multiple chronic conditions pose a significant and increasing burden on the health of Americans. We all know why they're important, but I'll just give you a few. Approximately 1 in 4 Americans have a multiple chronic condition, including 1 in 15 children. Among Americans aged 65 years or older, as many as 3 out of 4 persons have multiple chronic conditions. People with multiple chronic conditions are also at increased risk for mortality and poor day-to-day functioning, and multiple chronic conditions are associated with substantial healthcare costs in the United States. HHS provides leadership in improving health outcomes for individuals with multiple chronic conditions. The department's vision for multiple chronic conditions is an optimum health and quality of life for individuals with multiple chronic conditions. One of the main steps taken toward achieving this vision was identifying 4 interdependent areas: strengthening the healthcare and public health systems, empowering the individual to use self-care management, equipping care providers with tools, information, and other interventions, and also supporting targeted research about individuals with multiple chronic conditions and effective interventions. So I wanted to move to the next phase of what we're trying to do with public health. And the Public Health 3.0 initiative is led by the U.S. Department of Health and Human Services, Office of the Assistant Secretary for Health, and builds on the work of Healthy People 2020, which encourages collaborations across communities and sectors. It is an evolution of the healthcare system. So we look at Public Health 1.0 and what we think of as the first era. The focus was on acute and infectious diseases, and the goal was to reduce death. We're currently in the second era, as I just talked about, with 2.0, and the increased focus of chronic disease with the goal of prolonging a disability-free life. And so what Public Health 3.0 is what we would like to move towards, with a shift in focus to achieve optimal health and producing optimal health for all. Public Health 3.0 calls for us to boldly expand public health and address all aspects of life that promote health and well-being, including those listed here: economic development, education, transportation, food, environment, housing, and safe neighborhoods. Over the summer, the Assistant Secretary for Health embarked on a 5-city tour across the nation. Those cities included Nashville, Tennessee, Allegheny, Pennsylvania, Spokane, Washington, Santa Rosa, California, and Kansas City, to include both Missouri and Kansas. And from those meetings, a report was generated from all of the feedback received, and here are the recommendations. We recommend a chief health strategist that does not necessarily have to be a health professional or someone that's in public health, but just someone that can empower everyone. A structured cross-sector partnership, enhance accreditation where possible, actionable data and clear metrics, and searching for ways to have flexible and sustainable funding when we're looking at public health initiatives. To achieve Public Health 3.0, we need to draw on leadership from both the public and private sectors that impact community health, work collaboratively to improve health outcomes and advance health equity, empower local leaders to be chief health strategists in their communities, and increasing stakeholders and working to foster creativity and innovation across sectors. And a great example would be the various meetings that are held across the city examining how housing, transportation, community development, and planning intersect. So next, let's look at healthcare reform and diabetes management. The Affordable Care Act, or ACA, contains numerous changes to the existing U.S. healthcare system affecting in one way or another every U.S. citizen. As it stands now, it's law, and that may change, or we may have a different iteration of it. One major reason for the law was to provide health insurance to approximately 40 million Americans who were not covered by some type of health insurance. And it was also designed to address specific deficiencies that existed in the current healthcare system. And to better understand the specific sections of the ACA that directly relate to persons with diabetes, we need just a brief overview. There are 2 basic mechanisms within the ACA that are designed to increase insurance coverage for eligible Americans, because not everyone is eligible as listed here on this slide. And the eligibility for Medicaid benefits will need to be expanded to include individuals below 138% of the federal poverty level, or FPL, such as Medicaid expansion. And I'm sure you all know that 3 out of the 4 states in Region 7 have not expanded Medicaid, and this is a map of the United States that depicts the states that have adopted and the states that have not adopted as of October 2016. And so we know that Iowa is one of the states in Region 7 that took a customized approach to expansion. And so here is a list of how the ACA benefits a person with diabetes. The Medicare donut hole is closed, and the donut hole, as you may recall, is a gap in prescription medication coverage that occurs once all deductibles and co-payments have been met and once a set ceiling on annual payments has been reached. And then once reached, those with Medicare Part D may be responsible for 100% of prescription drug costs until a yearly cap on out-of-pocket expenses maximum has been met. And so with the ACA, that donut hole was closed. We also have non-exclusion of pre-existing conditions, the prohibition on limiting lifetime annual benefits, free preventative services, which we'll talk about more in a second, permission to stay on parents' insurance plans. The ACA also authorized the creation of the National Diabetes Prevention Program at the CDC in order to eliminate the preventable burden of diabetes. A diabetes report cards for the purpose of enhancing diabetes surveillance and quality standards across the country was developed, and plan types that cover catastrophic medical expenses that a diabetic person may face was also implemented with the ACA. Here's a table depicting preventative services covered by the Affordable Care Act that may benefit individuals with diabetes. So as you can see, we have women, we have gestational diabetes screening, all adults, type 2 diabetes screening for adults with high blood pressure, and also just the other preventable services that are essential for someone with multiple chronic conditions as well as a diabetic individual. We also have some concerns for a diabetic patient that may come from the Affordable Care Act, including just those individual costs to individuals, variable acceptance of expanded Medicaid by state, confusion of coverage because at certain times, it was difficult to discern what was covered and what was not under the Affordable Care Act, and just an over-reliance on high deductible insurance plans. So I have to mention that open enrollment 4 started November 1st and will continue until January 31st, 2017. December 15th, 2016 is the last day to enroll in order to change plans that will be effective January 1st, but enrollment will continue until the 31st. And one of the OE4, open enrollment 4, national themes for this week is diabetes awareness. So this is very timely. Here are some of the resources, especially on Public Health 3.0 and more about diabetes and the Affordable Care Act. And this concludes my section of the agenda, and I truly appreciate you having me today, and I believe at this time we'll take questions.
All right, we haven't received any questions yet, but it's still open for you guys to text in, so if you haven't yet, text 22333 with IHC 2016. You receive a confirmation that you are in our texting pool, and then you can go ahead and text as you normally would. Just a note for you guys as we look to receive some extra questions as they come in. With your text messaging, some of your service data may cut you down to 140 characters, so just keep that in mind as you're texting your questions. And we have our first one. So, what do you anticipate being the major changes in the ACA and the new administration, specifically for diabetic patients? Big question.
Yes, that is a good question, and it's hard for me to answer because I'm not 100% sure as to what the plan will be. We know that the president-elect has said that there will be some sort of changes to the Affordable Care Act, but they have not been outlined yet. And so we are still in a wait-and-see moment to see what those changes will be and how it will look.
Thank you. And we'll give you guys another couple of moments here if you want to text in any additional questions. All right, we have our next one saying that they can't hear us. It's a poor connection. So we'll work on that to try to increase the audio for you guys. So thanks for texting that in.
Unless we're talking about Shary.
And we have one more question, fairly similar to the first one, maybe if there's an expansion on there, and specifically asking how this might be affected if the ACA is repealed.
I heard the question. I'm just thinking. It's really hard. Well, let me say this. It'll be really hard to repeal because it is law. They're with the president-elect and the current climate in the Congress. It very well may be a possibility. But we do have to understand there are a lot of different aspects to the Affordable Care Act and how it was presented and how it looks, if that makes sense. It's very much an onion. So you peel back layers, you peel back layers. There are so many different provisions and things that were created under Affordable Care Act. To just repeal the entire act, it will take some time. And with that time, we will have to discern what will stay, what will not stay, and how that will impact. And I would love to give you an answer and an estimate on when that will be, but I don't see that or foresee that anytime soon.
Thank you. We're getting our questions to start rolling in here. So the next question, how does the HHS Office of the Assistant Secretary of Health work with CMS and CDC? How is HHS involved with MACRA? Does everyone here know what MACRA is? All right, so MACRA is the Medicare Reauthorization Act with CHIP that came through and actually took a lot of the reimbursement changes for value-based care that were initiated with the Affordable Care Act and continues in past 2019. So they rolled all of that into the quality payment program, kind of merging those things together. So it continues the transition from volume to value-based care. So just a precursor there to the question.
And thank you for that, because I would not have been able to explain that so eloquently. So how OASH would work with CMS, we have a ongoing relationship. Now, I wasn't sure if it was CMS in DC or just CMS in general, but I'll just answer in general. We have a CMS regional office here. We have an OASH regional office here. And so we collaborate on a lot of various projects and initiatives. It's specifically to MACRA, our role would be to assist in educating and providing that awareness based on CMS guidance to those of clinicians and physicians that will be affected, and explaining, one, that knowing that the rule exists, and noticing that there are complications to the rule, and with that, just assisting CMS in spreading the messaging, if that makes sense at all. And did that answer the person's question?
We're getting some head nods, so I think that did well. Thank you.
Okay, okay. Mm-hmm.
We are getting a few questions that are asking about the availability of data on whether or not we have data for the ACA to show how many people are accessing diabetes prevention services, and if we've been able to show any kind of outcomes in diabetes improvement through those programs.
Yes, and would I have them readily available? No. With OASH, we will rely heavily on CDC, because that will be one of the things that was implemented and embedded within ACA creation of that surveillance program within the Centers for Disease Control. And I'm hoping maybe Patricia will be able to answer that. I don't want to put her on the spot, but that would definitely be a Patricia question.
All right, just waiting a couple more seconds to see if any additional questions come in. We have received a comment for the audience, just as a reminder for us, as we continue to talk about the ACA and advocating for diabetes prevention programs. We've received a challenge to reach out to our representative. All right, I think that's all the questions that we were receiving.
Well, I'd like to thank Shary Jones for that great presentation and appreciate you connecting virtually